Okay, well, welcome everyone to the first seminar of LSE Health and Social Care. I think we're very lucky to have John Bolton today with us. John is somebody who knows everything about social care in the UK, but also he knows about it from different perspectives. So he's worked at the Department of Health, he's been a director of social care services in 4 different authorities. You seem to have a preference for W's, you know. So 3 of those authorities start with a W. Just, I think you, a few days ago, no, you stopped being director at Walsall. And he's also got a chair at Oxford Brookes. So, as I say, you know, very, very well informed. And John is going to tell us about doing social care, you know, what can local authorities do in the context of these cuts in public expenditure that we're experiencing. He's going to talk about 40 minutes. Happy to have questions about clarifications, but otherwise hopefully we'll have some time at the end for a more you know, broader debate. Thank you very much.
Okay, great. Well, thank you, and thank you for inviting me. I feel really pleased to be here. I've got quite a lot of material, I realised when I was looking at it on the train. I'm going to try and kind of race through some of it. I'm going to try and first of all set the context that I see social care and the current policy. Tell you a bit why I don't think current policy will work. So pleased to see former colleagues in the Department of Health here. And actually then tell you a bit about an emerging model of social care that's slowly emerging across the United Kingdom. Actually, very interestingly, being developed almost by practitioners rather than by academics or by policymakers. So, and it's almost kind of like needs must. So the big challenge, the big question we have to face is: can we manage demand in social care at a time of increasing demographic pressures and decreasing resources? And you'd think the simple answer to that is not a cat in hell's chance. And that, I think, is the dilemma that many councils, in particular managing social care, find themselves in today. And that's probably true across the United Kingdom. We were just saying, I work in Wales and Scotland as well as England, and in Wales they have slightly protected social care from the levels of reductions that English authorities have experienced, and slightly similarly in Scotland, against different. In fact, it is quite interesting, and Louis and I have talked about, I've talked about these issues over the years. Over the last decade, the numbers of people being helped by councils has been reducing. Almost before austerity came in, combinations of policy and direction have meant that people in residential care, in England, in Wales, actually it's the way the graphs are. I think I need to change this. That's actually a faster reduction in Wales, use of residential care, and very, very interestingly, because this might be a lesson for what might be going to happen in England. This is Scotland, where it was reducing, then free personal care came in, and it went up, and now it started to reduce again. So there are some things about the care system that we need to understand, where actually fewer people have been helped before we got into the period of austerity. Now, again, very interesting, England, Wales and Scotland all have current care bills going through their parliaments, assemblies. In England, the care bill has a very strong emphasis on rights, and the rights of carers, rights of individuals, and the rights to funding. You may have heard a lot about the cap that's going to be put on social care, so that no one will be expected to pay more than £72,000 for their care. And those of us who know a bit about these things know that's an extraordinarily high figure. It probably equates to 6-8 years of care before before you would get your care paid for free. And most of us know that actually most people do not experience as much as 6 to 8 years of care. Care tends to come at the end of people's lives, if you're an older person in particular, which is what the CAT was developed for. So it's a kind of generous government policy that won't actually hit that many people. I'm sure, again, colleagues here will have done the maths as to what actually they think that impact's going to be. The governments all have continued with various versions of personalisation. Interesting, personalisation, which I was responsible for when I was in the Department of Health, has kind of like slightly different focuses depending where you sit in the United Kingdom. England has a preoccupation with personal budgets, which is not as strong in either Scotland or Wales in terms of their versions of personalisation. So the personal budget, where somebody actually gets the allocation of the resources and can take some more control over how that is spent, is not as big in the other countries. There's a very big focus, which is kind of almost emerging stronger in all three home nations, again in different forms, about the necessity to link health and social care, so to ensure that they are better integrated, and we'll come back to some of that. In England, part of that is the creation of this new fund, the Better Care Fund, which is an attempt to pool money across health and social care, particularly the money focused on older people, and particularly the money focused around older people who have episodes in and out of hospital. And all three countries have a version of well-being, of the importance of the overall well-being of the citizen. So that kind of sets a kind of the policy agenda. I think this policy is really going to be challenged by the policy that no one talks about. Certainly no one, it's very hard to get officials or ministers in the Department of Health to talk about the other side of the policy that's going on at the same time, which is actually clear. I mean, government doesn't make any secret of this, that actually we're in a period of austerity. They're going to reduce the amount of public expenditure. Very directly, the biggest hit has been made on local authorities and the reduction of monies available to them. That's bigger than any other part of the public sector. That's the loss of monies. There's round about a 25% reduction in the grants that governments give to local authorities over the coming 3 years, on top of a 10% reduction we've experienced in the past 3 years. Though it is worth saying this does vary enormously between councils, and quite perversely I'm finding with a piece of work I'm doing at present, the wealthier the council, the less impact this has, partly of course because the wealthier councils historically get less grants. So they don't get the grants, so actually they don't suffer so badly from the cuts. I was in a council yesterday that gets very, very little grant, and therefore a percentage of naught is always... But so it does vary, and of course it disproportionately hits Northern Mets in particular. So the councils are almost, I'll see what evidence I collect on the current piece of work I'm doing, almost you might begin to draw a line across the country and watch the graph go up as you head north. Adult social care, care, I was talking to a group of Rotarians, not a normal company I hasten to add, the other night, and I asked the Rotarians what proportion of the council's budget, these intelligent businessmen, what proportion of the council budget do they think care was? I included adults and children's, and they proffered 4%, 5%, 10%, and then somebody sitting there very thoughtfully said 50%. Well, council expenditure, 66% of what council spend goes on adults and children's care, slightly higher proportion on adults than on children's. So if you're taking significant sums away from councils, by very definition, if a third or more of your council's expenditure is on care, it's very likely that you're going to hit that care budget. And I think slightly disingenuous of the current coalition is they do not talk enough about that and its impact on care. They recognise, because they've been lobbied, we talk about the lobby groups, that actually there is a problem there. So they've put in a solution, which is this creation of this Better Care Fund. The Better Care Fund contains existing money that's being spent in the system, and kind of like says, well, if you pool sets of money that you currently spend and sit down as health and social care together and look at how you might spend it differently, will we get different outcomes? And there's a kind of question mark, and people of course think it is a part solution. Again, very interestingly, while this is all going on, another part of government has changed the funding formula for health, which means, lo and behold, they're going to bias the formula in terms of populations rather than deprivation. And when formulas favour populations rather than deprivation, they tend again to favour the wealthier south. So again, the council I was visiting yesterday said to me that the Better Care Fund, actually, because of the change in formula, there is some new money coming into the system, which they will be able to use and may be able to deal with part of the social care crisis that they don't have. So benefit again to the south, not so beneficial to the north. In the north, the formula is going to work against the allocation of health resources, which will make the management of the Better Care Fund very heavy. And it is worth saying, of course, the essence of the Better Care Fund is to try to help health and social care solve a problem that no one has solved for the last 50 years, which is how can we make the public less reliant and less using the acute hospital as their kind of place of refuge whenever they're not feeling well or need an intervention. How can we change the patterns to support people more in the community and less in their less in acute hospitals? What's interested me, of course, that's been the health policy for the last decade in particular. Been a lot of focus on that, the whole set of programmes. They've failed to tackle it. So an expectation that now with social care, will an integrated model crack it? And I'll say a bit in a minute about what I think it isn't. So I've touched on the kind of some of the critique of the care bill, and I'll kind of come back to some of this as we see it. I think it kind of like you can applaud the care bill because it's tried to kind of put all the care legislation of the last decades into one piece of legislation, but I think it's going to really struggle because of the scarceness of monies. And what is a point to say, actually, I was interested in a number of things I've read recently, and even in the last week. Local authorities, one of the things they're absolutely brilliant at is, with the scarce resources they've got, finding a way of using them, which is probably why government can kind of hit local authorities much safer than they can maybe hit other parts of government. So local authorities will make sense of this, but it may not be the sense of it that actually the government thinks it will. Now, let me just say a little bit about integration, because that does seem suddenly everywhere. Both sides of the major political parties, everybody is saying, well, the solution to all the problems is to get health and social care to operate as a single system. And there's a compelling logic from the customer perspective that if the customer is experiencing one organisation, not two, we'll say a bit more about the two in a second, that there'd be a logic to that being a much better management of that person's condition, more holistic approach, a more rounded approach. Unfortunately, the evidence doesn't support that. Most of the research that's ever been done, including some work I did when I was at the Department of Health, actually showed that when health and social care merge together, the health culture dominates, and the kind of culture that tends to want to see simple solutions for people, which is a common feature of the health system, prescribing solutions, tends to prescribe social care very readily in a way that actually pushes costs up and doesn't necessarily improve outcomes for people. Again, I'm going to come back to that theme. So the kind of issue here about can we create something that is compellingly right, but actually focus differently on the kind of outcomes that system achieves. And I think one of the things I've particularly observed in looking at this, and particularly because I do work in local authorities very directly, working with health colleagues, is of course what the priorities for health are not the same as the priorities for social care. Health is outstandingly brilliant, fantastic at interventions when you're ill. In fact, it will spend endless resources trying to diagnose and find out what your illness is and plot good interventions. But actually, they're less good at looking at the things that people might suffer from over longer periods. They take for granted particular things. And one of the pieces of work the Institute of Public Care did a few years ago was actually identify the big health reasons why older people go into residential care. One of the biggest areas of social care are these areas: dementia, incontinence. This is probably, these two are probably equal in their impact on an admission to residential care. Falls, stroke recovery and podiatry services. And if you look at kind of all the health priorities over the last decade, very rare. I think that featured in 1 year after a government had issued a paper on it. I've rarely seen any mention in health guidance on the importance of incontinence. There was a big push on falls 8 years ago. It has a very compelling research evidence behind falls, that actually if you capture somebody after their first fall, there's a set of tests and interventions you can offer people that almost certainly will significantly reduce the risk of a further fall. No, it doesn't feature highly in the health system. So this kind of concept that actually what you suffer from aren't the kind of priorities that the health service gives, and particularly what you suffer from in old age. And so a real kind of tension there, and some people might say, well, it might actually help health if it integrated with social care to actually realise the importance of these interventions in the health world. And that would be a good argument. It'd be a good argument if actually, because of their size, that health has tended, when integrated models, there are a whole lot of care trusts developed during the last decade. All of them were run by health, running social care, and in all cases, bar one that everybody talks about, the one case, Torbay, not the other 15 cases that actually didn't work, but the evidence was clear that actually it only increased demand and expenditure, and all of them bar about two collapsed just because they couldn't sustain the financial needs that the system was creating. In fact, even Torbay, that is well marked by government as being the champion of all champions of integration, the government doesn't talk about some of the things that have gone wrong there, which I think is really a shame. So actually, in Torbay, about 4 years ago, 3 or 4 years ago, the care trust there was at risk of collapsing because of financial pressures, particularly financial pressures in the local authority. So even the best example we've got of integration actually did have its own set of financial challenges. And I know that because I actually went down to try and help them sort those challenges out. Now, I'm not saying that integration is wrong. I'm just saying there's a kind of panacea that government's got, and a kind of what I think is slightly naive, rosy tinted view of integration, which actually needs much more careful looking at, much more consideration, and with much stronger focus on outcomes. One of the areas I've started to look a lot at in the last year or so is dementia care. And this kind of sense in the social care world has been that dementia care is going to be our downfall. More and more people living longer, more and more people possibly going to experience this dreaded disease, and once you have the disease, your quality of life will deteriorate quite quickly, and you'll only survive by expensive state-funded care models. Well, actually, we are learning a lot about dementia, and if you pull the whole lots of different things together, you could see that both from health and social care, there's a lot of evidence that actually how we should tackle dementia. In the first case, I've been very interested, mostly I read this in newspaper articles, so not from academic research, but usually they're newspaper articles quoting academic research, which is probably easier to read sometimes. Is that almost certainly now that the things that are most likely to cause dementia are very similar to the kind of same cardiac kind of conditions that are likely to lead to a stroke or other heart conditions. So a real kind of evidence set that actually, it's not unsurprising, connects with everything else we know, that if you took more exercise, including mental exercise, if you ate better and drank less alcohol, we'd all be much less likely to even experience dementia in old age. In other words, we're beginning now to understand at one level how we might work with populations to decrease the incidence of the disease. Of course, we also know, outside of the very successful public health campaigns on smoking, that other public health campaigns haven't had the same impact in terms of changing people's lifestyles. So it's probably a big question as to whether or not we can be successful in that. But we also know that if dementia is identified at an early stage, there are a number of things you can now do that will arrest the development of the disease, including, actually, the very same things: a better diet, exercise, and there are now some assistive technology, some apps you can download. The Alzheimer's Society are reporting some very interesting results in terms of people using mental agility tests to keep their brains recalibrated, working on problem solving, which keeps their problem solving functions working. So kind of some positive bits about how we manage dementia. We also know, again, as reported in papers, that there are drugs now being tested, and drugs, certainly one drug I've read, looks as if it is also going to arrest the development of the disease. Why is this really important? And behind all of this is going to be the kind of big kind of message I want to give you today. This is really important because one of the features of social care, unfortunately replicated in the Care Bill, is our preoccupation in social care with assessing people. Assessing people when they come to the local authority or the health service or whoever for help. Now, we know that most people come for help at a time of crisis. They kind of will have experienced something which has just tipped them over the edge into saying, actually, I think I need some help now, or I think Mum needs some help now, or whatever the issue is. the assessments historically in social care and the way the law has been framed and continues to be framed requires that you complete that assessment. We used to actually have to do assessments in 7 days. So somebody comes to you in their crisis, you assess them for the services that their crisis requires, and you give them the services to which they have rights to obtain. And this would happen with people's onset of dementia. What the legislation, the new legislation tries it, but I don't think quite solves it, is actually to recognise that you probably need quite a long period of assessment. First of all, you need, the concept has to be, actually, someone's come to you in a crisis, what are the interventions we know about that might actually help alleviate that crisis? What might actually change the nature of that crisis for you? And because of the nature of ageing, one of the biggest discoveries in social care has been that when you get ill in the 21st century and you're an old person, you're likely to get better. So when someone comes with a condition to social care because they've been ill, they've had an event, a medical intrusion, whatever it is, you're entitled, while you're lying in that hospital bed, when you're being assessed so you're not a delayed discharge, and you are rapidly being assessed so we can get a bed free for the next customer, your assessment is likely to be that you're not very well, you're not functioning extremely well, in brackets you being in hospital, and therefore you need quite an extensive long-term package of care in order to meet the needs you're presenting me with in that hospital bed. When actually, the most likely thing for many people is there will be some recovery once you get back on your feet, once you start the process of re-engaging, as your body heals, as you recover. But of course, the way we've delivered care and the way care is delivered, third parties come in and give the care, often means that actually you're almost frozen with the needs you had. The care delivered to you doesn't support your recovery. It tends to, in fact, in the jargon, increase your dependence. And the care you need suddenly becomes the care you need. And you get that forever and a day. So a kind of real challenge in the kind of care model and the legislation as to how actually do you tackle the issue which is portrayed by dementia around somebody comes to you, there's a whole sets of things both health and social care can do to actually help you with that condition. But actually, have we got it right in terms of getting that right balance between the intervention that ought to be available to you, particularly at that first port of call, and your long-term needs for care? So if we can get the interventions right, and if we could actually plot that between health and social care, I think there is a better chance that that an integrated model might produce some better outcomes for people. And there's a lot of talk about getting the care pathway right, about identifying risks in the community together. But of course the critical bit is getting the shared outcomes together. And at present, I would say there is a big gap between the aspired outcomes that social care might want to somebody to live a more independent life, and the shared outcomes that health might want to give somebody, which you might characterise as to be retaining a degree of health. And I notice it mostly in aspects in terms of who goes to residential care. In a lot of local authorities, the largest proportion of older people going into residential care are going direct from a hospital. would be considered to be bad practice in most parts of social care. And they're going into hospital because the consultant has prescribed it as a sensible solution for grandma. Families think it is brilliant as a care protected environment and takes a lot of worry off them. Blame them for that, but that obviously feeds into it. Even though most of the research would say that grandma, the last thing she wants to do is to actually to go into a care home. For most people, they would actually rather struggle on in their own homes if we could give them the right resources and the right times. And so it's kind of how do we break that cultural difference between health and care is one of the challenges that I think the integration debate needs to much more strongly focus on than the kind of some of the rhetoric that's currently around. For social care, if we think about the context in which we're in, with a large number of councils having reducing budgets, there's only two things they can do. They can reduce demand, I'll talk a bit about, and find ways of reducing demand, and I've been touching on that, or they can find ways of reducing costs. And we all know, actually, that social care has a really low cost base. Care is mostly delivered by people working within £1 of the minimum wage. That's the vast majority of the care workforce. That's what they're paid. So actually stripping more cost out of the system, yes, there are people making a profit out of care, but it's pretty marginal profits. And even those are now being reduced, particularly because local authorities, for example, for the last 3 years have frozen what they deliver. So I'm going to kind of conclude by just talking about what's then emerging out of all of this kind of thinking is a new model of social care, which, as I say, is mostly coming from a number of local authorities, mostly in kind of desperation. It's based on some thinking about what are the preventive interventions that we actually know, that I was referring to earlier, that can have an impact on people. It's based on working and trying to win partners over, partners in the voluntary sector, partners in housing, partners in health, to understand the model. And at its heart, it looks to every customer, every individual who comes for help, and says, what is the intervention we can offer you that maximises your potential for promoting your independence? It slightly cuts against the rights-based model that is also very strong in social care and in the legislation, because it also has at its heart two things. One is it expects the customer and or their carers to be proactive in this programme, and it expects them to take some responsibility themselves for the success of the outcomes that are delivered. In fact, in Wiltshire Council, they actually have developed a domiciliary care service where older people are assessed for their outcomes. The providers are paid according to the outcomes delivered and rewarded according to delivering outcomes that help older people become more independent. So you could see the kind of logic of what the system might begin to look like. I won't go into all of this, but very quickly, the kind of models of prevention we focus on is less so on the kind of what I call the public health models of prevention, which we talked about earlier, everybody keep fit and well. A bit on the kind of interventions that we begin to see and some of the outcome-based programmes that the Supporting People services developed during the last decade, a recognition that a short intervention for some people, very common, and for example, in tackling issues like homelessness, so an investment in somebody for a short period of time actually enables them to get back on their feet and function without any support, so those kind of principles. the growing evidence about restorative interventions, understandings of how we can help people recover, a big set of evidence in mental health services based on the recovery model in mental health, on the reablement model for older people, on the rehabilitation models that operate for people with disabilities. So a kind of understanding that there are interventions that can help, and then the deferred interventions which take us back again to dementia care, where actually particular interventions we can offer people will delay or defer when they're going to need more intensive care. And so these are the kind of assumptions that the new model is developing. And in Warsaw, the slides don't quite work. In Warsaw, we kind of developed the way in which we do the interventions, so that when people first come, we look at, well, what if there's a simple solution to their crisis? Can we redirect them to where that solution is? If there's a more targeted set of interventions, we then offered them a range of interventions, and almost everybody got part of this set of interventions before they were considered for a long-term service. And in essence, of course, what it means, probably in legal terms, is that everybody is being assessed through a process of interventions before the final assessment, which says, yes, okay, we've worked on a number of interventions, we now know what your long-term care might look like. Now, in all of this, it is probably worth saying that people who know me well know that I feel very passionately about this, and I think there's a truism here. In the early noughties, I came across a Canadian study which actually showed me what I probably knew already, and like any good academic, I found the research that proved my point, and therefore quoted extensively, is that what they found was that a little bit of care was bad for you. And what their study found, using control groups, all the right research methodologies, is that when they compared a group of people who had been offered a state-funded social care intervention, that group of people quite quickly deteriorated. Their care needs accelerated. Their care needs accelerated, according to their formula, by 120%. Compared to their control group, who had similar conditions but weren't offered state-funded care. The only exception this study found, which I think partly reinforced my view of the importance of reablement, was a view that therapists actually might make a difference. So the only intervention the state was offering that they could see positive benefits from in terms of somebody's well-being were from therapists. And so this whole concept of, and you can understand it in plain English, it actually makes sense. As soon as somebody gives up trying to manage things for themselves, they're likely to deteriorate quite quickly. And I think the kind of concept of personal resilience becomes really important in this. And what we notice, of course, is that there are people who actually are quite resilient, can live with quite a number of long-term conditions that might trouble them, but they find the personal resilience not to give in to them, to fight them, and others, for whatever reasons, don't have that resilience, and they may need care. For those who needed care in the Canadian study, there was also a 30% increase in their time of death compared to the control group. So quite an important impact. And ever since then, I've always held this in my thoughts, that the best I can do for someone is offer them an intervention, so it involves spending money on them, but an intervention that might give them a chance of not needing care in the long term, if we can. That doesn't mean nobody in Warsaw ever gets any help with care, closely untrue. But it does mean we gave everybody the chance to actually have that intervention, And we've even set up a performance system, which I don't have time to go into, to kind of manage that. It links to not making the decision at the time of crisis, trying to hold the person, and trying to do this in a way that still recognises people's dignity and control. So the message, I'm going to conclude now because I've just looked at the watch. The message is about plotting interventions and not doing speedy assessments. The message is managing the demand through a whole range of interventions I've started to, that kind of can be listed there, that shows we can actually do some of this. And in the end, we need both government and other partners to recognise the importance of the way in which these interventions work. And it's not just the solution. There's a lot of discussion in social care about getting the commissioning right. Actually, one of the interesting things I've observed as I go around talking to people about the emergence of this model is how important the practice of practitioners are in getting this right. I've done a study with a consultancy recently, and we identified that actually, whatever the eligibility criteria that the council stated it had, and in future government's going to state eligibility criteria, actually social workers determine for themselves what the criteria is and what the service is. And they found some really interesting patterns in this study, which showed that some social workers, well, a cohort of social workers will always prescribe what might be called an off-the-shelf solution, an existing commission service, a bit of domiciliary care, inter-residential care. Others were much more able to find creative solutions with people about the solutions that they needed. Right, I think I'm going to close there and take questions and comments. Thank you.
Thank you very much, John. We've got 10 minutes for questions and comments. Martin?
Okay, just your slide, just a couple back, you said we need better trained practitioners with the right skills to offer interventions, which you could say is motherhood and apple pie, although I don't disagree with you. But given the difficulty in social care, that so much of the provision is in the independent sectors, and so the possibility of influencing their investment in staff training is less direct. I mean, do you think that's a particular challenge? I mean, social care hits that challenge, I think, more quickly than healthcare does, for example.
Yeah, I think that's a fair point, Martin. I think that it's very interesting. I made reference to the Wiltshire model. For their model to work, they had to get social workers to change practice, commissioners to change practice, and providers to change practice. And a lot of time went into the provider organisations to make sure their staff much better understood that actually they weren't just rushing in to deliver the half hour of care. They actually had an outcome to deliver with the older person as part of the delivery of the care, and the outcome was geared around what am I doing that might help this older person regain further independence than they've already achieved. So I take your point that may be a critical bit. It's critical in that assessment phase. I would characterise the training of social workers, certainly for the last decade, social workers I talk to, they've been trained as advocates. They've been trained to assess people and then advocate against the nasty local authority who are rationing resources, how to get the best possible deal for their customer. That's not bad, but it focuses too much on the intervention. And it links, in a way, there's a feature here around where there might be a critique about an aspect of personal budgets, that if you kind of have rushed to assess somebody, allocate them the resource, give them the personal budget, before you've thought through the interventions, you may have done the person a disservice, even though the world calls it empowering the customer to take control.
Glenn?
Yes, so much of this,
what you're saying.
Yes.
I think you have to speak up so people can hear.
Yeah, totally sorry. Both rang true, but also really very deeply embedded in all the cultures. First, on the history of those cultures. What happened in the 70s was all the experimental argument about coordination, case management, was very explicitly based on an investment metaphor. It was based on trying to select out those for whom investments of an imaginative kind would work through to the kinds of benefits we describe. Why was it that this didn't go through into guidance in 1990s, early 90s, and didn't prosper that much in the following decade? Well, two things. First was that the emphasis at the top of the office of the ministers was not on what Griffiths called the keystone of his proposals. They promoted case management keystone down to a cornerstone status. The cornerstones don't make very much difference, really. Keystones are quite critical to the survival of the earth, the building. And why? Well, we know the reasons for that. Those were political. And when I was talking to, we were all talking to the directorates, people in middle management, in authorities in the early 90s. It is true the directorates, many authorities set up little working parties to develop their care management policies. But actually, I was told in one authority, one of the most distinguished authority run by President of ADAS, that, oh dear, yes, we set up this working party 2 years ago, turned to his director, what on earth happened to that? Their focus was really elsewhere. That's one thing that happened. Second thing that happened, well, therefore,
briefly, because we've got 2 minutes.
On using case management simply for spread very thinly, with fairly tick box responses, therefore, to handle a newly fragmented system. One. Two, social work is very much a group which refers to its own traditions and its own literatures. The report published last week, officially commissioned, look at the extensive bibliography. There are no references at all about work and the future of social work to anything that doesn't really come from a very narrow group of things. And the history that people learned of the care system really only began when the social work academics were involved in government.
So,
history started that day. So, yeah, these are what these and others I could continue.
I can tell. We know you can. Can you concentrate on the question, please?
Extraordinarily difficult cultures to change. They're very deeply implanted. We have to tackle the training of social workers, by Jove. Tackle the social work departments in universities, ho, ho, ho.
But see, what, in a sense, part of what I'm saying is it's almost in desperation because the traditional model is not sustainable as the money falls out of the system that is driving some people to finding new solutions. And it's slightly sad. I remember reading a book written about poverty in the West End and about the strength of the communities. And the author posing the question, do you have to create poor communities in order to create strong communities? Well, you hope the answer is no. And so what sometimes creates change is desperation. It's a shame, but it does.
David?
Yeah, I'm trying to understand the new local health economies at the moment. And it's quite difficult. But what I'm curious about is whether you have any opinion at the moment on how well these so-called health and wellbeing boards are working in terms of influencing the commissioning both of the clinical commissioning groups and the local councils, the social care services, and whether or not you see any sense that they are moving towards a more integrated type of service which is thinking about some of the issues you talked about when people get out of the hospitals and having more focus on independence and well-being rather than just on a clinical approach to managing people.
Okay. I suppose I meant to say during the presentation, and of course one of the biggest problems with health, when I was approached on the local radio station when the government announced health and social care integration as the order of the day, my immediate comment was it would be fantastic to integrate with health when health is integrated. Health is as disintegrated now as it ever has been in my 40 odd years in the business. The kind of the acute sector and its foundation trust model, the tariff that drives behaviours there, the mental health trust sitting away from that, and yet the acute trust complains about the older person who may have dementia. You know, that's disintegrated. The clinical commissioning group, GPs are self-employed employees, some active, some not in the process, a very disintegrated health system. So that actually makes it very hard to have conversations with health. And of course, most of that health conversation is not at the Health and Wellbeing Board. The Health and Wellbeing Board is, crudely, counsellors and GPs, not the renowned group of people to solve the world's greatest problems, he said politely. So I'm sceptical. I think there have been some good examples, probably because there's been some good leadership somewhere, either politically or in the GPs or one of the officers, that has used that opportunity to create those conversations. And I know, and I've seen examples of that working. Universally, I visited, how many councils? I visited 7 councils this last week as part of a piece of work I'm doing. Nobody mentioned the Health and Wellbeing Board as part of their solution. They talked about the Better Care Fund, talked about integration. Nobody mentioned their Health and Wellbeing Board. And I thought that kind of, and these were senior officers, this wasn't people who wouldn't have met it. So the jury's still out, you could say it's still young, but, you know, but I'm saying that with some trepidation because I read that the opposition party, the Labour Party, is developing a model where that'll be the commissioning body.
Time for one quick question if you've got one. Linda?
It is a very quick question. You mentioned this Canadian study several times. I wonder if you could give us the reference so we can get a look at it. I could. No, I can't. I'll email it. It's 2001, University of. I can't remember what the university is now. I'll get it for you. I've got it. Yeah, okay. You know it's kind of your place.
Yeah.
Thank you.
Well, so can we all thank very much John for coming and giving an excellent presentation that showed some of the challenges, but also some of the solutions, which is always very helpful. Thank you very much.